Dr. Joshi. I'm a consultant hepatologist here at King's College Hospital. I'm also one of the ERCPists and a transplant physician as well. So anastomotic strictures after a liver transplant are very common. We're one of the biggest centres sort of performing liver transplantation in the United Kingdom. And if we leave these strictures untreated, it can lead to the liver failing. So we need to be able to stent these strictures in order to preserve the graft. Historically, we've used plastic stents, which unfortunately mean we have a fixed diameter that we can insert. And these patients were coming back every 3 months for repeated ERCPs. And although we would treat the strictures, they would recur. And once they reoccur, then a lot of these patients need to have major biliary surgery. We've been looking for alternatives over the last couple of years to try and treat these strictures. One of our senior endoscopy nurses was flicking through an endoscopy brochure magazine for Taewoong, and they found these stents called Kaffes stents, which are designed for biliary anastomotic strictures. So we started using the stent in 2016. So for all anastomotic strictures that are suitable, we are now inserting Kaffes stents. We've done, I think, about 22 cases so far. But what we're finding is, improved efficacy of stricture resolution. So 88% we found had complete stricture resolution. There were sort of minimal complications. There was no migration of stent as we've seen previously. I think, however, the biggest impact has been that these patients don't need to come back for repeated ERCPs every 3 months. So once we've taken them out, so far we've not had stricture sort of, recurrence so far. Obviously this is an ongoing assessment, and over time we might find that these patients do come back. But so far, we've freed up a lot of ERCP slots for other patients. So overall our patients have benefited from this new stent. So this is a patient we've done here at King's. You can see they've got clearly a anastomotic stricture. This is pre-Kaffes stent insertion. And then this is at the time of the stent insertion. So ideally you want more than 2 centimeters away from the hilum. You can see the stent is in situ within the duct, and you can see the removable threads have been deployed. And then we normally bring our patients back sort of 8 to 12 weeks afterwards. And what you can see here, the stent has been removed, and now you can see the stricture is resolved. So we're trying to roll this out into a nationwide UK-based study, multi-centre involving all the other transplant centres and the satellite transplant centres, and see if this can be introduced as standard of care. We've had very good outcomes with this stent, and I think patients can only benefit from this.